here at Michigan Medicine. Um, and my subspecialty is in what we call stereotactic and functional neurosurgery, and it includes, um, it's really focused on dysfunctional neural circuits, so conditions like Parkinson's disease and epilepsy, and a significant component of that is in chronic pain, and that's also where kind of we encounter patients with facial pain. And so let me just kind of share my screen here a bit. Um, so I thought I would talk a little bit about, some applications of what we call neuromodulation for facial pain, or essentially, the implantable stimulators and that type of approach for facial pain. Um, I won't necessarily take up, too much time, and you probably don't want to hear me speak for forever. But I think I'd just give a very broad overview of the topic and some of my thoughts and experience with it, and then we can open it up more, probably more for discussion, might be more um, a better use of the time towards the end. So, can you guys see the full slide here? Does that look
Yes.
good? Okay, perfect.
Yep.
Okay, so I have no personal financial disclosures related to this talk, but I should mention that a lot of the devices I'm going to be talking about are technically off-label in terms of their application for facial pain syndromes. But off-label doesn't mean that it hasn't been done before. It's just not technically FDA approved for those specific things. So, I'll give a broad overview of facial pain and what neuromodulation can bring. It's something that you guys probably have more familiarity with than most people. I'll talk a little bit about, the concept of neuromodulation and stimulation, kind of the different types of devices we might use, and then really kind of the nuts and bolts of what goes into placing these devices. And I'll be interested to hear perspectives from you guys as well. Um, so you guys know that, there's many different types of facial pain. There's this like 100-page document that tries to classify all the different types of facial pain. Um, in neurosurgery, we are often chiefly focused on this subcategory of what we call cranial nerve pain. So pain that comes that we think comes from the trigeminal nerve itself, or along that sort of pathway in the nerves or the nervous system, rather than the mechanical like joints or muscles in the face, which might be more of the purview of like say ENT or dentistry, that sort of thing. Um, but even within this subcategory, there's many different types of facial pain. And for us as surgeons, it's important for us to really understand the type of facial pain that patients have, and then also match it with our interventions. Um, because, in neurosurgery, we only have what I like to say is certain hammers. And so if they don't, fit the nail, quote unquote, every procedure has some risk. So we want to minimize the risks and maximize the potential success of any sort of procedure that we do. So when we as neurosurgeons think about facial pain or trigeminal pain, you probably have seen this before, is the sort of the Kim-Birchall classification of different types of facial pain. Um, and the type 1 trigeminal neuralgia is one that we often talk about or think about because our most common hammers, so to speak, the microvascular decompression, gamma knife, and the percutaneous lesioning of the trigeminal nerve. Those procedures are most useful for this type of type 1 pain. So that's the brief, lancinating, kind of shocking pain with pain-free intervals in between. Generally has very clear triggers. It can respond, at least initially, to medications like carbamazepine and oxcarbazepine. So we do have a few options for this type of pain, this very specific subtype of pain. But what about these other types of pain? So pain that's caused by either intentional or unintentional trauma to the nerve, patients who have facial pain as a result of something else, say multiple sclerosis or a tumor, um, or someone who's had uh, a herpes zoster or shingles outbreak on their face and they have residual pain after that. That gets us into a kind of a category of pain that there's actually not that many very well established treatments for. So this is where, the concept of neuromodulation has been applied to some degree of success. So here we use the idea of neuromodulation. Um, Mainly, it's a word that is an alternative to directly doing something to the nerve. So either cutting it or lesioning it or doing something directly physical to the nerve. With neuromodulation, we're using usually electricity to stimulate the nerve, and that signal kind of changes how pain is perceived in the brain or how pain is transmitted to the brain. And so that's our goal in these techniques. So in neuromodulation, a lot of it is based on this, what we call a gate control theory of pain, which is a little bit of an older theory, but still has its uses. Um, so if you ever imagine, if you ever like bang your knee on some furniture, you kind of rub it like this to kind of get the pain to go away or kind of cover it up. So the idea is that this type of vibration or touch sensation in the spinal cord in the brain actually competes with the transmission of pain signals. And so with stimulators or neuromodulation, we provide that sort of distracting signal constantly to try to keep pain from getting transmitted to the brain. So we say that yes, there is some pain signal from the nerve, from the trigeminal nerve. It's an inappropriate pain signal, but we can't necessarily change that directly with a surgery on the nerve, say. So we can use these stimulators to keep the pain from reaching your brain, so you can kind of at least get on with life. Like I said, it's not a direct effect on pain transmission. Um, and because it is based on this sort of like competing nerve transmission, it's best for what we call neuropathic pain. And guys, feel free to stop me at any time in the middle if you have questions or want me to explain something if I'm going too fast or anything like that. Um, But so neuropathic pain, it's something that we, as surgeons or clinicians will want to get a sense of when we meet you and discuss potential options. So often neuropathic type pain is described as either shocking, electrical, or zapping or tingling. Sometimes it's kind of a burning or a numbing or a sandpapering kind of feel. Um, it's less it's not so much like a sort of aching or like joint or like spasm type pain that you might see in like TMJ or something like that, or like arthritic pain. So it's important for us as physicians to kind of tease apart what type of pain it is, so that we can again um, know what to expect in response to a stimulator device. Neuropathic pain can be constant or come in triggered attacks. So in contrast to that classic type 1 trigeminal neuralgia, even a constant neuropathic pain could still respond to neuromodulation. In general, it does tend to respond better to sort of nerve type drugs like carbamazepine or oxcarbazepine. Also, the other drugs like gabapentin or pregabalin are thought to target more this nerve type pain. And it usually doesn't actually respond as well to opioids and narcotics or NSAIDs or things like that. Um, so if we feel that the pain is, chiefly neuropathic in nature, then we might consider a neuromodulation device for it. So a neuromodulation or a stimulation device has a number of parts. The one is, of course, the stimulating lead or electrode. So these are the parts that are implanted under the skin next to the nerves or other target to provide that stimulation that covers up the pain sensation. Um, Many devices have what's also called an implantable pulse generator. So a device might be placed, say, under the skin with wires that travel through the neck, and then with a generator placed in the chest here. That generator is like a pacemaker that provides that constant sort of stimulation around the nerve to quiet down that pain signal. There are some systems, newer devices that just have a receiver under the skin, and the actual device that provides the stimulation is external. So it's like a pad that you might wear over like your neck or over your back or your chest. When you're wearing that, it provides the electricity through the skin for the stimulator. But otherwise, you don't have to necessarily have the battery around with you all the time. So some common conditions that have been approached with neuromodulation, things like occipital neuralgia, the trigeminal neuropathic pain, which is a pain that comes from injury to the trigeminal nerve branches. Um, the similar to this, what we call deafferentation pain, which may be a result of injury or numbness from prior treatments. Postherpetic neuralgia, the pain that comes on after a shingles outbreak. Um, what we'd call symptomatic trigeminal pain, which is due to something else like multiple sclerosis or a tumor or a stroke or something like that. And then, of course, this condition we call thalamic pain or post-stroke pain. Um, there has been trials to address that with stimulator devices as well. One thing that I should kind of emphasize about these neuromodulation approaches is that they're typically not like a 100% cure. So, we know that these abnormal pain signals are still there. We're providing the stimulation to at least cover up or distract the nervous system so that there's a reduction in the perception of pain. But, and you'll see some of the numbers that I'll kind of throw up. It's not, you know, always like a home run necessarily in terms of curing pain necessarily. So, why should we choose stimulators over other, approaches like nerve transection or other approaches to the nerve? Well, one of the benefits of stimulators is that they can be adjustable. So if your pain changes over time, or if things do change over time, you can actually adjust the stimulation parameters, the strength of it, to kind of try to keep up with the evolution of the pain over time. And it's reversible in the sense that you can shut the device off if you need to. And if it's really stopped working for you and you don't want the device and you can remove it without having caused, injury or unreversible damage to the nerve or other part of the nervous system. Um, Other procedures that sort of damage the nerve produce numbness as a side effect. So stimulators typically should not produce any further numbness. Um, and then the other sort of big drawback for nerve damaging procedures like resection or compression is that the pain can come back. The nerves naturally want to try to heal themselves, and they often heal themselves in sort of the incorrect way so that they start sending the pain signals again. Whereas a stimulator can provide stimulation for as long as the device is in place. What are some of the drawbacks of stimulators? Well, one is MRI compatibility, mainly because, and I'll talk about this a little bit, mainly because when we're using these devices to address facial pain, they're often devices that were originally made to treat pain elsewhere in the body. So when we apply them to regions of the body to cover facial pain, it's not been officially approved to undergo MRI with these devices in these locations. So you may not be able to have MRI with certain configurations of these stimulators. And then another drawback is the fact that you have these implants in your body and you have to deal with them. So Aaron was just saying that he had a recent battery change. And so when these batteries poop out, you may lose your stimulation and the pain comes back. And so you have to undergo yet another procedure with some risks to get a new battery or change the batteries if you have an implantable battery system. So just real quick, I was going to go over some different types of neuromodulation, kind of different strategies that we might use in different circumstances. So, and I was going to kind of start from the outside in. So, one common thing that's used is peripheral nerve stimulation. So this places a stimulator device just under the skin, say covering one of the divisions of the trigeminal nerve. So you can have one just over the eyebrow to cover the supraorbital nerve, one just under the sort of the eye to cover the infraorbital nerve. You can place one here in the cheek to try to cover the mandibular nerve. So if you have pain only in one division or maybe one or two divisions, this might be a good approach. Um, some people have tried placing stimulators up into the skull base where all three nerves come out into the through the foramen ovale, and that could potentially cover more areas as well. Um, if you look at some of the success of some of the studies, you'll see that all the studies are very small, like at most maybe 10 patients with a couple years of follow-up. It's kind of a flip of a coin. So maybe 50 or 70% of patients have at least 50% improvement with these types of procedures, depending on the underlying diagnosis. Um, and so, like I said, again, it's not 100%, but for some people it does work pretty well. The benefit for this type of peripheral nerve approach is, again, it's non-destructive, it's adjustable. You'll see this line through every single one of these options, because that's a common theme for neuromodulation. It's removable if it ends up not working or changing over time. And it can be more selective. So if it's clearly, say, like a case of shingles that just came through one division and you only have pain in one division, then we can really be selective and target that one division. And because everything is just under the skin, it's a little less invasive, a little bit less risk in terms of injury to the brain or spinal cord. The drawbacks of a peripheral nerve approach is that it's usually not MRI compatible, because we're using usually devices that were designed for spinal cord stimulation and instead placing them under the skin. So they sort of fall outside the category of MRI compatibility. And again, like I said, because they're not designed necessarily to be placed right under the skin, and the skin and the face and the scalp can sometimes be pretty thin. There's risks that the electrodes can move, or it can even like erode through the skin, or cause like other areas of irritation where they kind of come close to the skin surface. So that can become a separate issue over the long term as well. Another approach of stimulation is actually spinal cord stimulation. So spinal cord stimulation has been around for a long time. It's typically used to cover pain in the low back and radiating into the legs, just because that is a more common condition. But as you'll see in this diagram, the trigeminal nerve nucleus does extend down from the brainstem into the upper part of the spinal cord. So sometimes if we can thread a spinal cord stimulator, which is placed next to the spine, in the epidural space in the back, that can sometimes reach high enough to actually get the trigeminal nerve and you can get stimulation into the face. It's a little easier to cover kind of the lower face than try to get it up into the first division of the trigeminal nerve based on how the anatomy is arranged, but sometimes it is a good option. Again, there are not too many large studies. Again, about half of patients with about 50% improvement in their pain with this approach. The benefit of it, though, is again, it's a neuromodulation device, so it's adjustable, non-destructive. Because it is a spinal cord stimulator used in the spinal cord, it's more MRI compatible depending on the brand that you choose. So if MRI compatibility is very important, this might be at least an approach to try first. Like I said, it's easier to cover kind of the lower part of the face or over the ear. But because it's based on spinal cord stimulation technology, it's a very, very well established device with well established companies that provide it. The drawback is that it may be difficult to cover like a large area of the face, like the whole face, if you need that. Both of these devices often do better when there is pain but still some preserved sensation in the face. If the area of pain is completely numb, sometimes it's better or sometimes it's thought to move better to more sort of brain-based stimulation. So one thing that's been written about a lot is motor cortex stimulation. So the brain is organized in various areas that tend to do better, that are responsible, quote unquote, for certain things like language or vision. This dark green area is what we call primary motor cortex, and it contains the cells that send their signals to the spinal cord and eventually to the muscles that tell our muscles to move. But there was a discovery that actually, if you stimulate in this area, you can actually improve pain perception. And there is an organization of the motor cortex so that certain specific areas of this motor cortex actually subserve the facial areas. And it's a pretty large area because there's so much that happens that we use our faces for. Motor cortex stimulation has been applied for cases of refractory facial pain. Again, very similar numbers in terms of the trials, which have very low numbers, about 50%, on average, about 50, 60% improvement in the pain. What happens is usually there's what's called a craniotomy, or a little hole that's made in the skull. The device is placed over the motor cortex, either outside the epidural space, or some people place it under the epidural space to get closer to the brain. And again, the wires kind of run under through the neck and then to a generator that's in the chest to provide the stimulation to the brain. So again, it's a stimulation device. It's not destructive, it's adjustable. It is technically removable. I put a few dots there because, as we get more invasive in terms of our options, the more, not difficult, but the more it would take to remove a device once it's in there. People tend to think about motor cortex stimulation when it's more of what we think of a central type of pain, like after a stroke, or if somebody has complete numbness on the face, that we think providing more stimulation, under the skin won't necessarily change things. So that is something we would think about. The drawbacks are similar to before. There's nothing that's specifically designed for motor cortex stimulation. So typically people use spinal cord stimulation electrodes that are just placed over the brain instead, and this makes them not MRI compatible. One thing that people have noted is that because this is electrical stimulation of the brain, there is an increased risk of seizures, especially as you turn up the stimulation to try to get control of the pain. And there's a question also of kind of long-term benefit. The brain, for better or for worse, is incredibly good at learning. And one of the functions of the brain is learning to be kind of a filter for signals that, well, the brain likes new things, and it doesn't like, kind of monotonous things. So if these devices are providing, just a very plain stimulation for sort of years and years, sometimes the brain kind of adapts to it and tries to like filter that out. So a lot of people who have a lot of experience in motor cortex stimulation have many different programs and many ways to kind of keep the brain, quote unquote, sort of entertained, and so to keep the stimulation effective over time. So you kind of have to, sometimes you have to keep cycling through different types and patterns of stimulation, otherwise the brain gets used to it. A similar approach is what we call deep brain stimulation. So this is stimulation, but targeting, rather than the surface of the brain, deeper structures that are sort of along the pain pathways. So sites in the thalamus, which is kind of like a relay station between the body and the brain, the periaqueductal gray, which is a very kind of a central pain site in the brain, even areas of what we'd call the internal capsule, which are trying to target kind of that, what we'd call the affective component of pain. So not just the pain and sensation, but that sort of punishing psychological aspect that makes pain so unpleasant, of course. Again, you're seeing this 50% number. It's a very, again, sort of 50% people are successful with their trials, and about half of those get good benefit over the long term. But again, things can sometimes change over time. The benefit of deep brain stimulation, again, it's a device, so it's not destructive. Removal would take another surgery, of course. Um, it again is maybe a better way to address central pain, so pain that is coming from the brain itself. Um, you wouldn't necessarily expect stimulation on the face to change what's happening in the brain itself. And there are some areas that are, again, trying to address that sort of psychological, and what we call like emotional affective component of pain. Because actually this should be in the pros section, because it is the DBS device that's typically used for tremor or Parkinson's. Typically, these are MRI compatible. Um, some of the drawback is that there's not a lot of experience using deep brain stimulation for pain, so it's debated, what are the best targets that provide the best benefit. And again, this question of long-term benefit, if the brain gets used to the stimulation, sometimes you have to keep changing things up, reprogramming, providing new signals. Otherwise, the brain will get used to it and the pain comes back. There are other technologies that fall under this category of neuromodulation, which um, I personally actually am not as experienced in what you might see, so I thought I'd mention that. So one is transcranial magnetic stimulation. So this is a technology that's becoming more and more popular, as we understand it, but it's often actually used through psychiatry. But it's this device that kind of is positioned outside the scalp, and it uses magnetic currents to sort of induce um, electrical signals in the brain. And these sort of like pulses can actually induce changes in the brain that are beneficial for whatever you're trying to, whatever neural circuits you're trying to change in the brain. And so some people have used it for pain conditions. The other devices are wearable stimulators. So it's sort of like these peripheral nerve stimulators, but instead of having an implant, it's something that's like put on the skin. Of course, the benefit is that you don't have something living in your body. You don't need a surgery for it. But it's, something that only works, or at least, you have to keep using on your skin um, to get the benefit. Then there's some early studies using what's called focused ultrasound to try to address pain. So focused ultrasound is a newer technology that uses kind of this helmet of ultrasound emitters to create heat-based lesions in the brain. So the benefit of that is there's no incisions and no anesthetic that's needed. Um, but the drawback is it's a kind of a permanent lesion in the brain. So whatever happens kind of happens. It's sort of like um, the idea behind Gamma Knife, but it's a little bit more of a immediate result from it. So so that's kind of the overview of the actual strategies and devices that we use. I thought I might touch also on some of the practical aspects, which um, can sometimes become, which I think shouldn't be, but sometimes are more of a burden than the actual thinking about the actual device themselves. So of course, whenever we think about these devices, we do want to make sure that we've maximized, of course, the less invasive options. So medications, working with, a pain management group, including neuropsychology, to sort of maximize all of those components before we consider, invasive surgery or implants or things like that. Sometimes we may ask the pain doctors to do what's called a nerve block, at least as a trial, especially if we're thinking about a peripheral nerve stimulator. So if we block the supraorbital nerve and all of your pain goes away, even at least for a short period, that might give us more confidence that stimulation of that one nerve will provide a meaningful improvement over the long term. And then it's, of course, always meeting with the proceduralist or the neurosurgeon who has a specialty in pain or these sorts of devices. So someone who has this sort of stereotactic or functional specialty training, or some people are calling it sort of restorative neurosurgery at this point. I think that part is important just so you can get a good sense of all the pros and cons of every option that's available. If you meet with a general neurosurgeon, they might just say, well, you're not a candidate for microvascular decompression, and that might be the end of the line. But a discussion of these stimulator devices or their approaches um, might still be in the cards if you have somebody who's a specialist in this area. So let's say you meet with a pain doctor and a surgeon, and they say, well, you might actually be a candidate for these stimulator devices. So part of the process includes a neuropsychology screening. Um, so some of the reasons to do this are to make sure that other psychiatric conditions are controlled. So depression or things like that don't get in the way of the success of the stimulator devices. Just making sure there's no issues with addiction or substance use, making sure the social factors are not a problem. You don't necessarily want to be putting these implants in someone who might be homeless or something like that. You want to rule out early signs of dementia, those sorts of things. A lot of this neuropsychology screening also checks the box for insurance. We're going to kind of talk about this a little bit, but before a lot of insurance companies will approve even a trial of stimulators, they'll want to see you having a clearance from a pain or a psychologist for these reasons. Sometimes you can do with stimulators what's part of the process is a trial. So I think neurostimulators have this as a benefit in that you can quote unquote try before you buy, especially in the realm of peripheral nerve or spinal cord stimulation. It's relatively less invasive to do a trial where they place an electrode that kind of comes out of your skin, and you have this external battery for about a week or so you can see if it works for you or not. If it doesn't really work for you, you just take out that temporary electrode and you can kind of try other things. But if it doesn't work, then you move on to the permanent implantation with a permanent battery and things like that. Of course, it's easier for peripheral nerve or spinal cord stimulation where this is sort of like a standard. It's much more difficult to do a trial with procedures in the brain. And again, sometimes with stimulators, a trial is part of the checkboxes you have to go through before they will approve a final implant. So just that sort of on that insurance topic, sometimes insurance approvals themselves can be very burdensome. And because we're talking about using stimulation for pain or facial pain, there are some battles that you get into with insurance companies for approval. And these are just some screenshots from some insurance web pages where they will say any peripheral nerve stimulation device anywhere in the body is investigational, it's not medically necessary. So sometimes you run into these challenges, which sometimes are surmountable with enough, pestering insurance people, but it can take a lot of work sometimes. So I'll just put that out there, especially when we're talking about motor cortex stimulation or deep brain stimulation, that can become much more challenging to get approved for a pain indication. And then, of course, there are drawbacks to stimulator devices. So the leads can move and you lose your stimulation if they move to the wrong location. If the devices are under the skin, so if the skin breaks down or the incisions break down, that can lead to infections. And so you have to go back to the OR to have these things taken out to clear infections. The brain-based stimulators like motor cortex stimulation or deep brain stimulation can have an increased risk for seizures. You can get side effects from stimulation. And then the system itself can have problems. So wires can break, batteries can poop out, that sort of thing. And then again, the issue of MRI compatibility is something to discuss. Not everyone needs an MRI all the time, but if you do know you're going to need an MRI, let's say you do have a tumor or multiple sclerosis or something, then it's something you're going to want to consider before you kind of dive into having a stimulator device placed. So So that's kind of it. So, I'll be happy to hear what everyone else's experiences are, and see what if there are any questions for me or any input.
I'd like to just say, I can hold up my old electrode. This was the electrode that was used,
Mm-hmm.
the motor cortex stimulator, which was on my brain. So it's got four little paddles, and it's very flexible. And I think this was stitched onto the dura, if that's
Mm, okay.
to say it.
Did you say you had yours with Dr. Schwab?
Oh, go ahead.
Did you say you had yours placed with Dr. Schwab?
This one was placed by Dr. Jeffrey Brown in
Oh, okay.
2004,
Okay,
a long time ago.
great. It sounds like you've had some good success with it.
Yes,
Yeah.
very much.
The
Very
reason he has it in his hand though is he did have an infection, the wire coming down, so
Uh,
it all had to be taken out and then put
yeah,
back in. But it was such a success that, we redid it. It was redone.
okay,
So yeah,
good, good.
and it still helps him today. So it's, he's never had seizures or anything of those problems.
No.
Okay,
Um,
good.
And he gets the ability to kind of control his settings. He asked for that for Medtronic, and they work with him on it. So that's
Mm-hmm.
I'll let you talk, Aaron, since you're the patient.
I can hold the thing. Now this is a new one for me.
Mhm.
It's got the programs right on it. But the programs actually reside inside the stimulator itself, and this is just the remote to turn it all on and off.
Mhm.
And let's see. It'll come up with different programs. I have program A and then different settings or electrode configurations to turn on and off
Mhm.
and and so on. There's A, B, and C with 4 programs within each one. So there's a lot of options, which is really good. And
Mhm.
again, it's non-destructive. It's just invasive because you have to do a craniotomy to get it to get it in there.
Mhm.
But there's a lot of options once you do finally get it in and go through the insurance hassles to get it in. Because yeah, mine took 5 months to get the thing approved back in '04. But it worked. It worked
Well,
very.
that's good.
Of course, this was for I have constant pain in the face.
Mm.
So I never had any shocks back then.
Mhm.
To confuse the issue even further, but it was only for constant pain.
Mm. Okay.
Very
Do you find you have to keep changing the programs around, or do you have like certain ones for certain situations, or?
no, I use 2 or 3 programs, and uh, I don't have once I find a setting that I like with the amplitude and the frequency and so on, I generally just keep it there.
Mm.
Um, I did find one setting that was good for the breakthrough pain. I would increase the pulse time
Okay.
or the pulse width rather, the pulse
Mm.
width. And that seemed to help that at least temporarily. Uh, the next good thing about it is even turning it off, I would get relief. It's
Mhm.
so it's just that change like you were talking about, just keeping the brain active. Um, uh, and don't allow the brain to learn.
Mhm.
Mhm.
Don't let it learn for too long because it will do that. It's good at it. And even turning it off, I would get pain relief.
Hmm.
Yeah,
Well, it's great to hear your experience with it.
it's been good. It's been good. I mean, of course, the infection was a pain, was an issue, but uh, I've been good since 2004.
Great.
Yeah, 20 years. Yeah, 20 years, right?
Mhm.
Yeah,
Yeah.
20 years.
Now he has shock pain too, but
Yeah,
that's
now I
different.
have, it's totally unrelated to the stimulator.
Mm.
Shock pain that started in 18 And I've shut my stimulator off for a couple weeks and just dealt with the pain just with my medications. And it had no effect on the shocks, none
Hmm.
whatsoever. So
Interesting.
we're pretty confident that the stimulator's not doing anything to make the shocks happen.
Hmm.
And that's about it for, I think, um,
Any other questions for Dr. Chen on any of the topics?
Well, I have a question. Is you mentioned that this is really more for like if you didn't if you have pain and it has more to do with trauma, like with the oral trauma
Mhm.
situation, would but it's in a certain location, we'll say.
Mhm.
Um and gabapentin does help with it. Now the odd thing about it is so does opioids. And
Mhm.
I don't like being on that. And I'm always afraid that it's going to stop working
Mhm.
because, yeah. And plus, too, it's not good being on this, but I noticed that you had that like ruled out as being like if your pain, your trauma pain, can be helped a little bit with opioid pain reliever, then it's not neuropathic, or it still can be.
It still can be. I wouldn't say that's a hard and fast rule. But in terms of, these are kind of shades of gray, but in terms of trying
Right.
to tease things out, and there may be multiple things that overlap sometimes. But in terms of trying to tease out, especially like what might respond to stimulation and what might not, that is sometimes a helpful um, metric to determine because stimulation is usually not that helpful for like musculoskeletal or joint or arthritic sources of pain.
Mm-hmm.
So if there's like a component of that, if there's like a mixture, it might help us kind of predict what could respond to a stimulator and what might stick around after a stimulator.
So if somebody were to come in, you could kind of figure out if it is something that would work or not, right?
In a very rough sense, yeah.
In a very
Yeah.
yeah, yeah. I mean, how would you go about trying to see how it would work for it? In say a case of where there's been trauma damage to the, I don't know what nerve or what,
Mhm,
but
mhm.
definitely it's a nerve. Um, part of the
Yeah,
part of the trigeminal, I'm sure.
right.
And it was with a lot of bad dental work.
There are
Were
a
they
lot.
over aggressive, and
Mhm,
and there was infection and blah blah, but that's
mhm.
how it started.
I see. Yeah, I mean, I think having that history of it being associated with the procedure or trauma is important. Um,
Uh-huh.
kind of just understanding the quality of the pain and where it is to sort of get a sense of what type of, is it neuropathic? Is it some sort of different type of pain? Is important. Whether you still have sensation in the area, or whether it's like like completely numb, is important.
No, there's no numbness.
Okay. So potentially, we can use that's when we can use that sort of distracting signal either from the nerve here in this under the skin or like up in the high cervical area to
Mm.
sort of distract and
Test it.
cover up
So,
that area
uh,
of pain.
would that be the motor cortex you're talking about, or
So truthfully, I think if you had chiefly pain in like the lower division,
there's an absolute area of it?
mhm,
Yeah.
and that's again, the opinions probably vary depending on who you ask. I probably would favor spinal cord stimulation as a trial first. One, because you can do a non-invasive or minimally invasive trial with like a temporary electrode that's just placed through a needle. The
Hmm.
pain doctors are very experienced at getting these epidural
Hmm.
electrodes into that cervical space.
Okay.
And if that's effective, The permanent implant still falls into the category of spinal cord stimulation. So, one, it's easier to get approved by insurance. And two, it's more likely to stay MRI compatible.
Oh,
Um,
that's
if it
good.
stays in that sort of spinal epidural space.
Okay. So, you would just make an appointment or well, how would you even begin on testing?
Yeah, so typically, I mean, I'm always happy to meet with people to discuss options and really, get into the weeds and figure out, the nature and quality of the pain and what options there are.
Mhm.
If we move towards stimulation, I typically ask my colleagues in pain medicine to do the trials if we're going to do a trial, just because they're so much better at getting epidural access. The anesthesiologists, they've done a lifetime of epidural catheters, in OB,
Uh-huh.
so they're so good at getting access in the epidural space to thread a temporary electrode in. Um, and they
Now,
have the neuropsychologist to do all the screening and stuff beforehand. If the trials is successful, then patients often come back to me for the permanent system.
so they would be able to tell, let's say, I'm in the pain, right? And
Mhm.
then they put through the, like you said, the epidural, whatever, and
Mhm.
I would know if, through the testing of it that immediately whether the pain, whether it was working, if the pain stopped.
Well, we do it. The trials usually for spinal cord stimulation, the trials usually last about a week. So they place the temporary electrode, and then part of it pokes out of your skin, and then you have an external battery that you kind of wear with you the whole time.
Hmm.
You can't take a shower during that week because you have a wire poking out, so that's kind of a pain. But other than that, you kind of test it. So because there's different electrodes on the wire, you can kind of test around to see location wise, where's the best spot that brings the stimulation to where your painful area is. And usually they'll produce like a buzzing sensation, and you
Uh-huh.
want that buzzing sensation to kind of cover up where your painful sensation is. Again, it's that kind of like rubbing the skin to kind of get the to cover up pain. So you want that
Uh-huh.
buzzing or tingling to cover the area of pain. And then once it's there, you decide over the week or so, did that reduce the sensation of pain? Did that improve my
Uh-huh.
function during this trial period? Um,
Okay.
if you say, well, I felt it in the right place, but I didn't feel like it changed the pain, then we just take it out.
Gotcha.
And then we say didn't really work. But if you say like, usually if for insurance purposes, the cutoff is 50%. So if you say, well, I think the pain felt, a little more than 50% better, and I could do more things or sleep better, then we would call that a successful trial. And then you go in, so the temporary has to be removed regardless, but then you would move forward with a permanent system.
Okay, you went out there a little bit. You were like stalled, so I don't know
Oh,
if I missed anything or not, but I think I think I have an idea of what you're saying. So
okay.
thanks.
Sure
Thanks.
thing, sure thing.
Now just not to change the dynamics of this whole thing, but you're a movement disorder specialist. So you do treat Parkinson's patients, I
It's
assume,
I Yeah, so I do the deep brain stimulation for
for
things like essential
Parkinson's.
tremor and Parkinson's. Yep.
Now, would you say that the DBS is more for tremor than it is for movement, or would you say that that's not necessarily true? That it can help with movement, like say, freezing of gait and things like that.
So what we say for DBS for Parkinson's is what improves with dopamine medications like Sinemet will
Yep.
improve with DBS. So if things like gait or balance or stiffness improve or speech improve with Sinemet, then those might also improve with DBS. If it doesn't change with the dopamine medications, it probably won't change with DBS either.
Well, the only reason I ask is my best girlfriend's husband, he has Parkinson's, and he does take Sinemet, and it does help, but
Mhm.
he is starting to fall more.
Mm.
Yeah, he's 72, so I mean, he's had a pretty long time, so he's been pretty lucky so far, but things have kind of gotten a little worse, and so we're all concerned about it. And then there's that talk of the focused ultrasound,
Mhm.
possibly coming along, and I don't know, where you are on that one, but
Yeah, if
it's in the
if he has
early
a lot of
stages, right?
it is if he has a lot of fluctuations with his Cinemet, then DBS might be an option. So he should talk to his neurologist about
He
that
does.
option. Focused ultrasound for that is very new, so
Yeah.
we don't know a lot about it. Um,
And where to exactly hone in on it, right?
we know where we create the lesion, but we don't have
Right.
a good long-term track record for it.
Yeah, it's too new, right?
Mhm.
Yeah. Yeah, I've been doing a little bit of research on that, and I did read that it started in Switzerland or something, and some of the US patients were going to Switzerland, and but even that, it's like no for sure real I mean, no 100% or anything.
Right.
Yeah, yeah, especially when it gets to the movement stuff, right?
Mhm.
Yeah. Okay, well, I just thought I'd ask you since I had you.
Sure,
had,
sure.
yeah, you seem to be, in that ballpark, that's your field. So
Yep, that is my area for sure.
yeah. Well, hey, that's a very important, area to be. I mean, Parkinson's is what I see him go through, it's a tough one.
It is tough. Yeah. Mm.
Yeah. Yeah. I mean, yeah. And it's been, around. I mean, there's a lot of stuff coming on the forefront, it looks like. Would you say that?
There is, but still a lot of work to be done too.
Yeah.
Mm.
Yeah. Okay. Okay. Well, thank you for answering my questions.
Sure thing, sure thing.
I have a question, Dr. Chen. Uh,
Yes.
Might be a little offbeat, but I know because we're talking about facial pain. But can this be used with patients that have CRPS in other areas of their body? I mean, I think
Yes.
facial,
Actually, no, go ahead. Sorry.
I was just going to say, I think that CRPS is rare in the face, although anything's possible, But I was just interested when you presented this. Is this an option for people with CRPS that have pain in other parts of their body?
Yeah, so actually spinal cord stimulation, one of the original indications for it was CRPS.
Oh,
And it
okay.
actually tends to be very, very successful for CRPS type of pain. Um, so yeah, definitely. Um, it's well established spinal cord stimulation in the arm or the leg is very successful for CRPS pain.
Okay, thank you.
Hmm.
Lynn, are you the one that your doctor had said they thought you had CRPS and it's in your face, or is that
Yeah, yes, but
okay?
when I went to see, I think that's kind of rare, isn't it, Dr. Chen? I think he didn't,
Yeah, I wouldn't necessarily, I guess I haven't really seen many people with it going into the face.
yeah, no, he said no, because he is a specialist, well, he's a pain doctor, but specializes in CRPS. He goes, it's not CRPS. Did you have a surgery to your face or a trauma? I said, no.
Yeah.
Said 40 years ago, I was in a car accident and my face kind of went through the windshield, but I mean, no. So he said, well, something's going on with the trigeminal nerve, obviously, but he didn't think it was CRPS in my face. He just said, I'm just going to have to call it a typical facial nerve pain.
Yeah, it's a probably a matter of some debate. We used to think that you always needed some sort of inciting trauma to cause CRPS, but then not everyone did, even in the limbs. And then some people, it tends to spread. Like they'll have it initially in the arm, but then it'll go to the leg or go to the other arm. So I think part of that is what we don't necessarily understand about what CRPS is or what causes it. Like I said, I don't see people talking about it as much going into the face, but maybe it's just being framed in like the wrong way. But maybe it's still worthwhile. Maybe that's why spinal cord stimulation that gets up high in the cervical spine still is helpful sometimes for people with, neuropathic facial pain.
Yeah. I don't think I would meet the criteria as I listened to your presentation. So to try that for my face, but it's interesting. I mean, it seems to have some advantages to it for people, and being reversible.
Mm-hmm.
It sounds like it has maybe less chance of negative consequences for patients.
Yeah.
So
Yeah, without, because you don't necessarily damage the nerve or, do anything to the nerve directly, then that's definitely a definite um, benefit or, aspect in its favor.
yeah.
Does anybody else have any other questions? I had a couple just because I was curious for
Yeah.
like the deep brain stimulation and what was the other one? The spinal cord. How are those surgeries done? Like how do you get to those places in the brain
Mhm.
for the spinal cord?
Yeah, so spinal cord stimulation for facial pain, I usually kind of approach it's kind of at the skull base. So
Okay.
we do make an incision kind of in the middle, in upper neck, kind of base of the skull here in the back. We approach and we kind of I usually put in a paddle electrode um, going down from the top underneath like the C1, C2 upper cervical spine.
Mhm.
And usually that's a good area to kind of cover at least the lower face. Um, that those wires then tunnel under the skin, kind of down the back to kind of like the flank kind of hip area for the
Mhm.
battery. So there's
Okay.
usually a separate incision for the battery there. For deep brain stimulation, it's a little more involved because we have to be so very precise in how we place those electrodes in the brain. So we usually use what's called a stereotactic frame. So there's this kind of frame you may have seen for like deep brain stimulation for like
Mhm.
Parkinson's. So this the skull mounted frame that we put on that we get a scan and that allows us to be very precise, sort of less than a millimeter of error when we're placing these electrodes deep in the brain. Um, we often want to do those procedures with at least some portion of the patient awake too.
Mhm.
So we'll place the electrode and we can actually test it. And if we're in an area, say like of the thalamus, we'll want to know that you're getting that sort of tingling, buzzing
Mhm.
in the face areas, the correct areas of the pain. Those wires are then kind of locked in by a cap that fills the burr hole where the electrode goes in. And then those wires travel under the skin to the generator in the chest.
Okay. Thank
Mhm.
you.
Doctor, is when you say like the buzzing, and is that like trying to distract the pain
Mhm.
from the brain?
Yeah, that's kind of essentially what we're trying to do is to kind of give
But will it feel like it's a buzzing? Yeah.
sometimes. So at least with spinal cord stimulation, there's a few options. The most traditional option is that you do feel the buzzing or the tingling. Um, and a lot of people actually prefer that.
Like it, like it.
Yeah.
Yeah.
Whether, it's not necessarily to a level that's bothersome, but like they'll know that they'll feel the buzzing and they know it's working and they know it's on. So
Yeah.
uh, there was a study about half of patients, even if they had the option to switch to a stimulation waveform where they don't feel it, and even if they rated their pain slightly better with the sort of non-tingling pattern, they still prefer to have the tingling just for whatever reason.
Mhm.
But at least with spinal cord stimulation, there are options now where you don't feel the tingling, and it just kind of reduces the pain, sort of signals going in.
That's interesting. Because I also have peripheral neuropathy where I
Mm-hmm.
have tingling. They call it tingling, but I call it more like stinging pain. Um, and that probably could be, an applicable situation like that too for maybe something
Yeah,
like.
actually, painful diabetic neuropathy, at least, is one of the
Mm-hmm.
newest indications for spinal cord stimulation. So it's not out there as much right now because they just sort of got their official FDA approvals, but um, more and more people are using it for painful peripheral neuropathies.
Wow. Okay. That's really interesting. That's great. Yeah. So, insurances are going along with it or?
I think for the most part, it still varies. Like it sometimes takes a while for insurance companies to catch up with the FDA.
Mm-hmm.
But insurance companies, to be frank, they don't love paying for implants. Um,
Mm-hmm.
so they sometimes drag their feet, and there's a lot of hoops to jump through. But it's
Yeah.
becoming, as for at least for diabetic neuropathy, is becoming more and more mainstream.
Okay. That's interesting.
Mhm.
Yeah. Wow.
Okay, any other questions? No? Well, thank you, Dr. Chen. That was
Good
outstanding.
thing.
It's a lot of good information. I think it was
Good.
very
Yes.
helpful for a lot
Thank
of
you.
people
Yeah.
in the group, and we have the recording also, so we can share
Perfect.
it with we shared some of ours with the FPA also recently, so that might be shared with them also, so they can
Okay.
um
Thank you.
Sounds
share it with
great. Yeah,
overall.
it was a
Thank
pleasure to
you.
be here. It was great to meet you
Thank you for
guys.
coming.
I think Danielle and Aaron have my contact info, so feel free to reach out to me or email me if there's any other questions or anything I can help you guys out with, okay?
Okay. Thank you.
Cool. All right.
Yeah.
Have a good night, guys.
Bye.
Thank
Good
you.
night.
Bye.
Bye.
Much.
Bye, guys. Everybody.
Mel, are you
We're
taking
staying
off?
on.
Oh, we're staying on?
Yeah.
Okay.
We're just gonna run through that as the first part of the meeting, and then
Oh, okay.
Aaron had a few announcements. Do you want to go through those or?
Could you read them?
Yeah, I can read them.
Not able to read very well.
So,
tonight.
Michael Wynn, I see you're on, and you shared with us your website, and so our videos are now on Michael Wynn's website, and that is on a link in the agenda that was sent out. So to see some of the past videos that were taken by Tim and Lynn, you can find them there. The 2024 Spring Journal is out. You've probably seen it. So there's a link there, and the has information for signing up for the what's it called? The
Oh, the conference.
the conference. So anyway, I'm getting too old. The words are escaping me.
Oh, I know. It happens all the time.
And then the link to subscribe to the newsletter, which I think everybody here probably
Mhm.
already does that. Then Aaron had a couple of notes about articles on new and ongoing research with Medifind, which actually that's something I use to find some more doctors in our area that oh, Katie Ryder-Myers, they're waiting to be admitted. Okay. To find some more doctors in our area, in the Michigan area, because on the FPA website, there are 0 listed. And different states have doctors listed. So doctors can partner with the FPA and be listed. So we sent a letter out to about 24 doctors, I think.
Yeah.
And a lot of them are ones that we already have and come to our meetings and things like that, have in the past. But there
Yeah.
were a few few more that we found, a few more neurologists, because we're very like kind of neurosurgery heavy, I feel like sometimes. So we're trying to get some more neurologists also. So that went out, and hopefully some of the people will respond. We've got Dr. Jacob is going to join us June 12th. And we invited all the doctors to come and speak at our meetings if they're available. So we'll see if they respond. So Aaron, you said, I didn't know this, but Medifine lists numeral clinical trials.
There's a spot in the Medifine at the, near the home portion of the website that lists clinical trials, and I found that with that link there, it'll take you to 20 clinical trials that are either ongoing now or recently started, and some of the past clinical trials are listed there too. There's some of them from 2022 and 21. And it's new information that I hadn't found doing Google alerts or Google searches.
Yeah, you usually don't hear too much about clinical trials for what we, for trigeminal neuralgia,
Right,
be it type 1, type 2, whatever, right?
right.
Yeah.
I haven't found hardly anything for oral facial pain in the past.
Yeah, yeah,
Nothing.
exactly. Oral facial pain. So that's maybe, it's becoming more, I think it is becoming more epidemic, let's just say, because they're doing more, well, at least for I don't know how everybody starts, who knows, right? But I mean, I know for me it was, and same for Tim, it was an oral trauma, we'll say. But I mean, I think with all the implants they're doing these days, and more root canals, and everything, and things, not, and some doctors just not understanding that, it's, it's because it's a neuropathic situation. It's not okay, we need to move on to another tooth, And yours, Aaron, even kind of started, you had a teeth cleaning, didn't you?
I'm sorry, say that again?
You had a teeth cleaning. That was the very, 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 very beginning of it all for you, right?
Yes, it started 2 weeks after I got my teeth cleaned, and that was so typical of so many people with TN and atypical TN.
Yep,
A couple
yep,
weeks later, the kindling got lit and the fire started up with either classic
yes,
TN with the shocks. It was
yes.
right out of the book.
I have heard, in fact, a friend of mine's friend, my friend told me about her friend that had had an implant done, and she was having all this, pain, and it really sounded to me. I said,